Thanks for joining us for this Facebook Live. I'm Elsa M. September is Prostate Cancer Awareness Month, and this month there is new hope about the potential of immunotherapy for African American men who are at increased risk of developing this disease. We have Dr. Benjamin Lowentritt from Chesapeake Urology joining us now. Thank you so much for being with us.
Thank you. Thanks for having me.
So I love Facebook Lives because it's an opportunity for people just to sort of chime in and ask questions. So feel free to do that as you're watching right now. But I want to start out with you, Doctor. How many men get prostate cancer each year? And are there certain groups of men that are more affected by it?
Yeah, so it's about 190,000 men that are anticipated to get prostate cancer this year, which is by far and away the most commonly diagnosed cancer in men. It's been a very large amount of cases that we see year after year after year. Thankfully, most men live a long life with their cancer, or their cancer is able to be cured. And it's not an aggressive disease in all of those men, but about 30 to 35,000 men a year do die of prostate cancer.
And in the past, what has the treatment been for prostate cancer?
So the treatments really depend on where in the stage of the cancer when it's found. In some men, if it's a very low grade, slow growing cancer, we may not even need to treat it aggressively. Okay. There's certainly, for other men that have local disease just in the prostate, there are treatments like surgical removal or radiation treatments that can be very effective at curing the disease. But then there's that subset of patients where the cancer spreads outside of the prostate, and then there's really no cure, but there are a number of treatments that we know that can really maintain a good quality and length of life, and keep the disease under control, hopefully for years and years.
And there are advancements now with immunotherapy. So can you talk about that, what it is, first of all,
Sure,
and how it's used to treat this cancer?
So, immunotherapy really just refers to any treatment that uses the immune system to fight the cancer. The immune system is the body's natural protection. It fights off infections. Many of us think about that. That's how our immune system, we talk about a lot lately with the COVID virus and trying to get the immune system activated with something like a vaccine. But the immune system is also the protection against cancers. And a cancer essentially is any cell in the body that's just learning to grow out of control and become more pathologic in ability to spread and cause problems elsewhere. So the immune system is in our blood, it's in our tissues, and it's there kind of acting as a guard to protect and isolate those cells that could become a cancer and wall them off and get rid of them. So on some level, in order for a cancer to spread, it has to trick the immune system to bypass that in a way, and to recognize that it's not a threat, so that it can grow and progress. So an immunotherapy is trying to essentially turn that immune system on more effectively to fight the cancer, essentially to do its job a little bit better. And the immune therapy we're talking about for prostate cancer is actually a kind of unique system where it's actually using the patient's own cells. It's a process where some of the white blood cells, those are what make up some of the immune system, are taken out of the body, and then it's taken out of the body and used to essentially exposed to different growth factors to get activated outside of the body. And then it's given back. In a way, this is now a personalized vaccine where it's your own cells that have, instead of just giving a shot where it tries to create this activation inside your body, which is what a vaccine traditionally does, right. Essentially that activation happens outside of the body, and then it's given back to the patients so that it's still their own cells. Huh. And now it can work to do what the immune system does, which includes getting the rest of the immune system engaged to fighting the cancer again.
It's really interesting how it all comes together. And I know that there was a study that was done as well, just sort of talking about the benefits specifically for African-American men. Can you talk about that a little bit?
Yeah, you had asked the question before, and I don't think I got to it, that overall it's about a 1 in 9 chance of men having prostate cancer. it's a higher in the African American population. It's about 1 in 6 to 7, and we also know that African American men traditionally, unfortunately, have had more high risk cancer and more chance for that cancer to spread. Typically, and I saw a question come up that said that asked about how often does the cancer spread. It's about 1 out of every 6 to 7 men that eventually will have cancer, that have prostate cancer, that will eventually have it spread. And we're finding that about 1 in 12 men may have it spread when we find their cancer. So we don't even have a chance to treat it locally because it's already spread once we find it.
So how do we get ahead of it? Yeah,
so there's multi levels of that, and the best thing we can say to do is to have the discussion with your doctor and make sure that your risk is being assessed and that you're having screening if you think it's appropriate. We recommend for all men really between the ages of 50 to 75 to be having that discussion and considering regular PSA blood tests, which is a simple blood test. The PSA is prostate specific antigen. So that's can be a regular part of annual visits to the doctor. If you know you have a family history of prostate cancer, and frankly, in the African American population, we oftentimes find a history somewhere in the family, we may recommend even screening a little bit earlier and certainly sticking with that regular screening regimen.
Now, has that changed? Because I know there are men in my life that have gone to get their screenings and their doctors have said, no, it's too early, even though for African American men, really, you're told that you should be getting it at 45, but then you go in at 45 and then they tell you, no, you should be 50.
Yeah,
so has that changed over the last couple of years?
It's a great question, and it is an important question because there is some controversy here. And I think there was a lot of confusing information that has been brought out in the last 8 to 10 years. There was briefly a recommendation that PSA screening should stop. Because the tough thing about prostate cancer is the time between when we find it and when somebody might die of prostate cancer often can be 8, 10, 12, 15, 20 years down the line. That doesn't mean that it's curable 18 years later, but that's when the patient may actually pass away from it. So even the disease that spreads sometimes takes a long time to do that. So evaluating how effective getting yearly blood tests is, you really need to take a long time to assess that. And there were some studies that came out that frankly were a little bit premature and suggested that after 8 or 10 years, there wasn't much benefit to screening. So now you have this question, are we potentially exposing men to harm by treating a cancer that's never going to become a problem? And as a urologist, all I can say is, we see those patients that die of prostate cancer. It happens, right. But we have to be very selective and and really make sure the patients are educated as to what their risks are. And when appropriate, like I said earlier, sometimes just watch the disease.
And when you talk about these studies, sorry to interrupt, but when you talk about these studies, who is conducting these studies? Are they medical communities? Are they insurance companies? Who is the one giving the directives?
So the studies that I was referring to actually were a couple of different ones that were medical groups. One of the big studies was done in Europe. One of the big studies was done in the US. Multiple different centers assessing, how the effectiveness, and then just following patients for a long time. And I don't want to get into the details of all of the trials because that can make us all our eyes roll back in our heads to some extent. But the bottom line was there just wasn't enough time. And as more time has come along with these same trials, we're seeing that difference and that benefit of screening is really there. It just wasn't clear early on. So the recommendation did go back to saying that people should be talking about this and having that discussion. So unfortunately, there were some mixed messages there. I think there's the more recent study that you had mentioned, and I want to make sure we talk about, was in those patients that unfortunately do have cancer that's spread. And we talk about the first line treatments usually are related to trying to manipulate the hormones that help feed a cancer and control the cancer by limiting those hormones. But as the cancer learns to grow despite that, there really are, that's when the disease is potentially lethal. And the study that you're referencing was a study looking at a treatment that's been around for about 10 years now, and looking at in real world practice. So this wasn't done just like in an academic center where in trying to get a drug approved. This was in real world, looking at how patients that got that treatment over several years did. Mm-hmm. And what was really interesting is that all men seem to respond and seem to the live longer if they get this treatment. Mm-hmm. But the benefit in the African American population was significantly better than the what we see in the Caucasian community. So, which is not something we see very often, frankly. We don't see often that there's a difference based on race. Certainly, sometimes we suffer from the fact that there's not enough minorities represented in some trials. Right. But it was really, powerful to be able to say, looking at this group, that the African American men seem to do better than their white counterparts that in this study.
Was there any reasoning that was given, or was it an anomaly that they just sort of said, wow, this is a surprising finding?
It's right now the answer is, wow, it's a surprising finding. I know there's a lot of research ongoing. Could there be a genetic component? Could there be something related to we never fully understood why the cancer was more aggressive in the African American population compared to the white population to begin with. Right. But maybe whatever that underlying reason is also makes them more susceptible and more successful with some of these treatments. So it's a very exciting finding because treating patients in the Baltimore area, I see a lot of African American men that are suffering with prostate cancer, and to have
the hope,
to have an arrow in our quiver that's a little bit stronger is fantastic.
And this is Dr. Benjamin Lowentritt from Chesapeake Urology. Just want to reintroduce you for people who are just joining a little bit late. What are the common side effects, though, for the treatment? I don't want to bring it down because there's so much promise in the treatment, but of course we want to get the whole picture. So are there common side effects that we should be aware of?
Yeah, it's what's wonderful about this treatment is because it's using the patient's own cells, and it's really not a treatment like a chemotherapy or others that's trying to destroy cells directly in a different way. This has fairly minimal side effects. The side effects we see are similar to what people have from a vaccine. Some people have a little bit of body ache or fatigue kind of feeling. And then also similar to what people have sometimes during blood transfusions, which can be a little shakes or chills at the time of the treatment. But what's remarkable about this is for most men, the next day they're back to normal. So, it's not most men have almost no side effects. We actually give people a little bit of Tylenol and some other, some medicines just to help prevent any of those minor side effects. Sometimes people just feel tired that night. But by the next day, most patients really are feeling back to normal.
And is it just that one treatment, or does a treatment have they come back several times?
So it's a course of 3 treatments. Each treatment is sort of a 2-part process where they have some of your blood removed, then it gets sent off to be processed to create the treatment itself, and it's given back, and that's repeated 2 more times. So you get a total of 3 cycles of the treatment, usually about 2 weeks apart.
All right. Well, tell us a little bit more about your practice, just the overall practice of Chesapeake Urology. What is it that you all do there? I know specifically they can come to you for this, but give us sort of a scope of your services.
Sure. No, I appreciate that. Yes. So Chesapeake Urology is a urology focused group. We actually have over 80 physicians and 100 providers overall. We're throughout the Baltimore metro area, on the Eastern Shore, in Montgomery County, Prince George's County, and up in Carroll, Hartford. We're sort of all around Central Maryland, and have offices throughout the different communities. And urology is a field of we really see a variety of things. You're hearing me talk about prostate cancer, and we do see other cancers like kidney and bladder. But we also take care of people for urinary problems of all sorts, men and women, for kidney stones, for enlarged prostate, for urinary incontinence in women. So there's really a wide breadth of what we do. We take care of children for certain problems, and so we really provide the full scope of urologic care across Maryland.
And normally, do people come to you by way of referral, or if someone watching right now, can they just call and make an appointment and go to you directly?
Certainly, we have different ways to get in with us. Some insurances will require a referral from a primary care doctor, but we encourage people to look us up on the website, to call us, or you now can even schedule yourself through an app. So it's really very easy to get in to see us if you have a specific question or a specific problem.
And how long have you been with the practice, and what do you enjoy most about what it is that you do?
Thanks. So I've been in practice since 2006.
Mm-hmm.
There's no replacing getting to know patients, getting to work with them, getting to help them. Urology is a surgical specialty to some extent. So I love that sometimes that we get to take sort of advanced techniques and surgical options. But what's also great about it is we do have a wide breadth of what we can offer to people, from medical treatment to minor procedures to things, really cutting edge things like what we're talking about today, and then surgery as well. So I love that I'm able to sort of fully take care of my patients in that way, and have a great group of people around. We have some people like myself, I've sort of developed into more of a subspecialty within the specialty, but still see other patients as well. And we have doctors that focus so that we can make sure that we're providing the highest level of care internally, but also see, a broad scope of different issues.
And I have to imagine that has got to be a relief for your patients as well, that they can come to the practice, know that there are 80 doctors. So if they do need someone that has a subspecialty, that can sort of all be handled in-house with the entire team, correct?
That's the goal. That's what we hope to do. So yeah, thanks for saying that. But absolutely, it's, our goal is always to put the patients first and figure out how we can make things work.
And as we wrap up, with Prostate Cancer Awareness Month being this month, what is it that you want our viewers to really know, keep in mind, not just this month, but moving forward for themselves and for their loved ones?
No, thank you for asking that. And yeah, September is Prostate Cancer Awareness Month. It's a really important thing to make sure to talk to the man in your life, your father, your brother, your son, your husband, and make sure that this is on their radar. If you are considering the issue, bring it up with your physician if you don't think you've been checked, and really just to make sure that this is continuing to be an issue. We know that one of the important things, and it was seen in this study that we're referencing today as well, each treatment, each issue that we see at every stage of the disease, if there's something we're going to treat, it's more effective the earlier we find it. So, putting our head in the sand and doing some of the things that as men we want to do, and ignore any of the signs that can be an issue. You don't want to do that. And this is a disease that frankly doesn't have symptoms until it's way too late. So, we find this through a simple exam, through a blood test. So you need to make sure that you're pursuing that, and that's a really important message for the month, to make sure that we stay ahead of the disease, because at every step we want to make sure we're offering the treatment that's needed at the earliest possible point.
Absolutely. Take those preventable steps early. Dr. Benjamin Lowentritt, thank you so much for being with us for this Facebook Live. I'm sure you're going to get a lot more questions. So if people want to reach out to you, how should they do that? Just go to the website? Yeah,
that's the best way. Go to the website. My practice is in the Towson area, but we do have, as I said, we have offices across the Central Maryland area, and we can certainly get you in to see somebody and get any of your questions answered.
All right, Dr. Lowentritt, thank you so much for being with us. Really appreciate it.
Thank you so much.
All right.